Um, First of all, thank you for inviting me to speak to you all today. I'm really excited to see so many of our patients from CIBD, some from San Diego, as far away, and far north of Santa Barbara. Having been in Southern California for a couple of decades now, I'm honored to say that I'm taking care of some of those grandchildren of patients that I've cared for in the past. And I just want to, again, thank you for this great honor. And I'll start this talk because Michelle gave me, and I'm gonna show you the quote that Michelle asked me to cover on this. And so I entitled it, Bleeding Disorders, A Brief Review of Everything, because what she asked me to talk about was the genetics of bleeding disorders. Do you think you can encompass all bleeding disorders, von Willebrand's and platelets too, and the latest developments also include hemophilia A, B inhibitors and platelets? And does this not sound like Michelle? At the end, she goes, is that too much? Classic Michelle. So I thought a lot about it, and what I'm going to try to do today is take a step back, because many family members are very, very focused just on their particular factor deficiency. And sometimes it's hard to see or understand how your deficiency actually results in bleeding in the context of everything else. So today, what I'd like to do is to talk about how we approach, first of all, making the diagnosis of a bleeding disorder, and how your particular factor deficiency, no matter which deficiency you have, whether it's factor 1, as we heard in afibrinogenemia, or it's factor 8 or factor 13. I saw that there's some of our factor 13 deficiency patients on Willebrand's. Whichever one it is, I hope at the end of today's talk, you will have a better understanding of how your deficiency fits into the total mechanism of hemostasis. And hemostasis means the control of bleeding. And so we'll talk a little bit about that. I'll throw in the genomics as well, because that applies to everybody with a factor deficiency or platelet disorder. And after we do that, we can talk a little bit about something that I'm very passionate about, and that's that research is being led now by patients. And they've kind of stepped into the driver's seat and said, this is what we want you to be doing work in, and this is what we want to participate in. So by the end, I hope that you'll understand more about hemostasis, you'll know where your clotting protein is, we'll know more about the genomics, and in the end, I hope that many of you will step up, as many of you already have, to help us understand more about bleeding disorders through the Athens projects and through research that's being done at your own hemophilia or hemostasis thrombosis center. So that way, I think I will have hit on every one of your requests, Michelle. So many times we are confronted, or someone will come in to us referred by their pediatrician because their child has increased bruising and bleeding. And many of you who have a child with hemophilia will recognize these bruises. If you have a child with a platelet disorder, this will also appear the same to you. If you have factor 13 deficiency, these bruises look familiar. So how do you sort out which of these disorders someone has, and how do we understand that they all work together? Well, I'm going to show this graph, this schematic, to you a number of times. And by the time we get to the end, I hope that you will have much more comfort with it. Every time I present it, actually, I'll be honest with you, I see a new nuance. And just for starters, though, we're going to go to the very, very top of the screen where that explosion is occurring, because this is where clotting and repair starts to happen. And it's very important that you notice that, and I'll explain what things are. This is a blood vessel wall These cells that are slightly red are called endothelial cells. They are actually the lining within the blood vessel, and they play a very important role both to promote clotting and also, importantly, to turn it off. And over here, you'll see on the side that there's a structure of the wall downstream from the clot that is responsible for, and these red lines mean breaking or blocking clot formation. So one of the things that immediately starts to happen as soon as you start to form a clot, you also start trying to control how big it is and how large it is so that you don't make a clot, you don't clot up your whole circulatory system. There has to be a way to control the size of the clot and make sure that it just stays at the place where the damage occurs. And you notice here's the damage. There's been a hole kind of blown into the blood vessel. That happens just with day-to-day trauma, the work that we do day-to-day. And so our body is constantly repairing blood vessels at all times. And this green little thing here is a really important substance that is in the wall of the blood vessel, and that's called tissue factor. And as soon as that tissue factor is revealed, the clotting system takes hold. And I will go through this kind of in a different way than you're accustomed to, maybe than reading in textbooks, because if you look at all of the factors and the platelets and the vessel wall working simultaneously, you get a much better understanding than if you just talk about one, the clotting proteins or the platelets or the vessel wall separately, because they're all working together simultaneously, not only to make a clot, but to slow down the clot formation as well. And some of the new therapies, as you know, are actually focused at making that break a little bit less effective. So those are treatments where we're blocking antithrombin 3 or tissue factor pathways. If we slow down the break for some patients, it allows them to clot better. So we're even making use of those breaking mechanisms to find therapy for patients with bleeding disorders. So just that's an aside, and I can answer questions about that later, but it's important to know that the people who are researching in clotting and bleeding are using all their tools, not just replacement of factor, but slowing down the breaking mechanism to get the ideal treatment for patients that have bleeding disorders. So getting back to the main actors, here's where damage occurs and tissue factor is revealed. This is a huge signal for the factor 7, which is in our bloodstream. Here's factor 7. As soon as it sees that tissue factor being revealed, it likes to bind right away. And as soon as it binds, it activates other clotting proteins. And if you have factor 10 deficiency or factor 9 deficiency, you can see what an important role those factors play right in the beginning of clot formation. And the same with factor 7. And actually, one of the more common rare blood disorders are people with factor 7 deficiency. And you can see where having a low factor 7 is going to cause some bleeding. And in fact, if we look at the factor 7 molecule itself, each one of these little bubbles in here is an amino acid. And this is a typical size protein. The tissue factor is about the same size as factor 7. And when it's revealed, factor 7, here it is, each with its amino acids, binds to the tissue factor, it gets activated, and in this schemata, it starts activating factor 10. And factor 10 then continues down the cascade to activate the clotting proteins so that eventually we have a fibrin monomer, that building block of our clot formation. The thing I want to show you here, though, is look at all the different places that the factor 7 contacts the tissue factor. So if you have a variant or a mutation in your factor 7 protein and you don't cup or bind that tissue factor as well as you should, you might have problems with activation. So this is the concept of why it's important for us to understand the genomics and understand why certain mutations can cause a protein not to work well. There are other mutations that just result in no production at all of the factor VII, but we're learning more and more about the variants that are not working as well, even though a protein is being made. And for those of you that have either factor VII, factor IX, factor II, or 10 deficiency, right down here in these sort of red areas, this is where vitamin K makes a difference. We talk about the importance of vitamin K. It changes the protein molecule so that it works better. All of those clotting proteins are dependent on good vitamin K levels. Vitamin K is processed by bacteria in your gut, and then you absorb it. If you do not have those changes from vitamin K in your protein, the calcium cannot bind, and then the protein does not work. This is why it's so important to give babies vitamin K injections right at birth, so that they can quickly get more functional proteins that are dependent on vitamin K. Very, very important, and you can see them again. Here's factor 10. It also has vitamin K sensitive sites where the binding of calcium is really important for the protein to be functional. So all of you that have either 7, 10, 2, 7, 10, 2, or 9, those are all very important for vitamin K. So that binding event occurs and it starts triggering these other clotting proteins. There are people that have factor V deficiency, factor II deficiency, which is a precursor of thrombin. And once thrombin is activated, that's another sort of explosion event, because it can not only proceed all the way down to forming the fibrin monomer, those building blocks of the clot, but thrombin plays a very important role over here with the platelets. And I know a lot of people, even on your board, have children or themselves have platelet dysfunction. And let's just talk a little bit about how the platelets play a role in clot formation as well, because as I showed you that child in the beginning, that child actually had a platelet problem rather than a clotting protein problem. And yet it looks just like everybody else in a way. So hold on a second. I should say, if there are questions or problems with hearing me, please, I ask the moderators to interrupt. So I meant to mention that in the beginning. So here's a platelet, an unactivated platelet. It kind of looks like a piece of pita bread or a Frisbee, so that it can fly through the circulation. You don't want it sticking any place where it shouldn't be. And the endothelial cells, again, play an important role in keeping the platelets from sticking places where there's no damage. But when there's damage, then they definitely stick. And in an area of where the tissue below the blood vessel is revealed, one of the first things that the platelets do, it's kind of like Teflon, they'll just stick, whether even without being activated. If there's an area of unprotected or damaged blood vessel, the platelets will stick no matter what. And that is a hugely important step, because once they stick, then there's a message to go ahead and activate, and that starts bringing in a lot of the clotting proteins as well. So here are the platelets coming. They see the collagen, which is underneath that damaged vessel, and right away, using receptors, and also, oh my gosh, this is when I can mention von Willebrands for Michelle, so Michelle can tick off von Willebrands. Von Willebrands is a key protein for all of us because it's one of the sites where the platelets do this adhesion. They call it tumbleweed rolling, because once they get there, they'll just stop. I also make the analogy that if you've ever had kids at one of those fun zones or areas where they can put on one of those suits and jump and stick to a wall, that's kind of what platelets can do. And they can do it even under very high shear. So platelets play an important role in coming in and sticking as soon as they see some damage. And after they do that, they begin to secrete and change their membrane so that they can bring in other clotting proteins. And one of the ways that they get activated is through those collagen receptors. And they have, just to make sure that they get activated, there are at least two different categories of collagen receptors. So we know that it's really, really important for the platelets to do that. And platelet and its interactions with von Willebrand's protein not only are based on that binding, and these little yellow things now are platelets, just so you know, not only on the importance of stopping and sticking, but as soon as they stick, they start activating. And one of the first things that they do when they activate is to release these substances, all of which play an important role in making platelets stick to each other and also activating the platelets that are nearby. So as it gets activated, these are signals to the platelets that may be flying by to say, hey, come on over here. We need to plug up this hole. And in fact, that's what we call it, is a platelet plug. And so now here's fibrinogen, a really important protein that is in the platelet that helps mediate the plug formation. So the platelet's like a little sack of clotting proteins that when needed, even though it doesn't activate in areas of no tissue damage, as soon as it gets to tissue damage, it is power-packed. It's like the Swiss Army knife. It has everything that it needs. It sticks, it degranulates, it activates, and it starts right away binding fibrinogen so that that network, those building blocks of clotting, start wrapping around and forming a network. And so this is what it looks like in real life. Here's these resting pita bread-like platelets, but as soon as they started hearing, their whole surface starts to change completely. These extensions are linked to actual little muscle fibers in the platelet itself. And the clotting proteins start spinning off of these extensions and off the surface of the cell, but particularly off these extensions, because the last phase of a platelet plug formation entails those long fingers with the clotting proteins on them suddenly contract. The muscles, at about 15 minutes into clot formation, the muscles within your platelet actually contract, and that whole netting comes down and you form a nice tight plug. So blood can flow through, but there's a nice tight seal over that hole. And it is really a miracle. It happens very quickly. People use platelets to study muscle function, if you can believe it. And that contraction event is just the same, works the same way as the muscles in the big red muscles in your limbs and all throughout your body. Again, here's the platelets starting to get activated. And one of the things that these long fingers do is that they begin to stick and actually form adhesions to that. You can imagine the blood's flowing through like crazy, but the platelets have to stick. And as they stick, they begin to spread. So the initial group of platelets that stick, kind of like a fried egg, just their surface area becomes much, much more extensive. And then the activated platelets that are flowing by stick on top of them, and they start forming the clot. I think it really helps to see this in real time, because now this membrane is the platelet membrane, and you begin to see the clotting proteins that attack. Activated factor 7 or NOVO7 acts here as well as at the site of bleeding in order to really begin to get that clot formation going. And so the last step of platelet plug formation is the incorporation of fibrinogen and clotting proteins into that fibrin monomer. And particularly, we find a lot of fibrinogen and a lot of von Willebrands in that plug. Much of it has been brought together by the platelet itself, but also an activated platelet can now pull the fibrinogen and von Willebrand's antigen from the circulation and incorporate it. If you think about it, our blood is full of fibrinogen and full of von Willebrand's protein, and it doesn't stick to the platelet. And that's because it will only stick once the platelet is activated. This is another a miracle of how we're all made, and just the miracle of clotting, really, is that all the building blocks you need are bathing that platelet, but they will not bind until you get to the site of damage, and it'll only bind when the platelets are ready for you to bind. Really, really wonderful. And if there's anything wrong with that mechanism, then we have a pathologic clotting. And that's not the topic for today, but today, if you want a blood clot to form, you need to have platelets, you need to have clotting proteins, and you need to have a well-balanced blood vessel. The last piece that I'm going to show in the clotting cascade is the role of factor 13. And we don't really pick that up in your clotting assays, PT or PTT, but it plays a really important role to stabilize the clot, especially once it's contracted. And in fact, we know that if you don't have factor 13 to stabilize the muscle as it's pulling down, contraction will not occur. And one of the ways that people first diagnosed factor 13 deficiency was that when you had blood in a regular glass tube, normally a clot forms and then the clot contracts. And in factor 13 patients, we saw no clot retraction and no stabilization of the clot. So even those early days, we knew the importance of factor 13. Factor 13 helps to keep the clot from being broken down too quickly by, again, those enzymes that are activated as soon as this occurs. I love this slide, except that the platelets look like red cells. And so these are actually platelets, and it shows that process again. Here's where the endothelium is trying to keep the platelets from sticking on the surface until there's breakdown and damage. The platelet then sticks, it activates, it releases all the substances that starts bringing in the clotting proteins. Here are the clotting proteins bringing all the platelets together. We call that loose aggregation. But that finally, with clot stabilization, here's what happens. Nice, tight clot that is going to be there for a while, even under high shear. And so that's the interconnection of all of those things. Now, when I talk about platelets, we've been looking like there's just one or two receptors. In fact, the platelets have over hundreds of different proteins in there that help them work. Their relationship with calcium is very, very important. A lot of these receptors are different receptors for different activating proteins. Here's that thrombin again, the factor 2, ADP, thromboxane. All of these things help to make the platelets activate. Here are many of the receptors that help to make the platelets stick. Here are some of the receptors that help them contract. So, and a variant or a mutation in any of these proteins, and this is the short list, can cause platelet dysfunction. So working out platelet dysfunction is a very important role that we do in our lab and other labs across the country to try and understand where the defect. Now, the most common platelet dysfunction that many of you know about is called Glanzmann's, and it's a problem with the 2B3A molecule or alpha 2B beta 3. Excuse me, that's a very important protein because it not only helps with adhesion, but it also helps, when activated, with binding fibrinogen. We also know about glycoprotein 1B causing something called Bernard-Soulier, but another very common platelet disorder that we see, particularly in pediatrics, is the inability for people to secrete and activate appropriately. And that doesn't cause as severe a problem as Glanzmann, but it does cause significant, what we would call moderate bleeding disorders. So we need to be able to diagnose all of those so that we can make advice to patients about their care and what they need to do. As far as platelets going, and because I'm really committed to genetics, I want to highlight some of the work that was done in our lab. Now it's almost been 10 years ago, to look at that collagen receptor. And remember how important it is, the collagen receptor, in that first step in getting platelets to stick. here are two different normal people with a minor difference, just actually one nucleotide difference in this position 807. It doesn't even cause a change so much in the protein. In fact, what it influences is the amount of collagen receptor that's on the surface. And again, this is a very subtle single nucleotide kind of difference that makes a difference between all of us. So some people have nosebleeds, some people don't. It's a minor kind of problem. Maybe it happens once in a while. Some women say, oh, my periods are a little heavier than other people. Maybe you bruise a little bit easier, but we wouldn't ever really find a major bleeding problem in doing your workup. But this is something that is what we call an individual variation. This person has roughly 10 times the concentration of collagen receptor on their platelets normally than this person. And what happens is that it in an additive way can cause a tendency more towards more clotting. And if you have less collagen receptor, you have a tendency toward bleeding. And we did a paper about 10 years ago now that showed that people that have von Willebrand's are much more likely to have this than they are to have this. And in fact, when we did this work in our lab, one of our fellows, we always torture our fellows and make them be in our experiments. One of our fellows that had this mutation, actually, we discovered had von Willebrand's. He had very low levels of von Willebrand's, and yet he never bled. So these subtle changes, we call these gene modifiers, can make a difference in your bleeding tendency, or another word that we use for that is phenotype. So you can have von Willebrand, but if you have this other variation in your platelet function, maybe it compensates, because look how fast the platelets adhere in this person compared to this person, where it actually takes them 2 minutes to even start getting close to what someone can do here in 30 seconds. And again, this doesn't result alone in and of itself with a major bleeding problem, but in addition to von Willebrand's, maybe factor 8, factor 7 deficiency, you tend to bleed more than a normal person that has the same level of factor 7 or factor 13 or von Willebrand's. Whereas this person, if they have von Willebrand's, doesn't even know that they have it. It's a gene modifier. So we're interested not just in the genetics of the gene itself, but what are the other genes that play a role in whether you bleed or not, even if you have the same level of deficiency as the person next to you. So these influences are going to become increasingly important as we get better and faster at looking at the other genes.
Y te saliste, Rosa. Te saliste.
Oh.
De la reunión.
Oh, is that okay? I hear someone talking. Was there a question? No? Okay. I'll keep going just to stay on track. I'm paying attention to the time. So many patients note something called petechiae. These are little dots. We see them when the platelet plug does not form fast enough. And what happens is that the red cells actually escape. So these are little areas where red cells have escaped out into the skin before the platelet plug has formed. And so it's always a sign to us that there is a platelet dysfunction, as well as if you have hemophilia and you, or a factor deficiency and you have petechiae as well, that kind of makes us want to look at how the platelets are functioning, or if your platelet level number is normal, because this can also be a sign of a low circulating platelet count. And why is that? Here, we talk a lot about bleeding mucous membranes for platelet dysfunction. So the Glanzmann's patients or patients with degranulation problems often will complain of nosebleeds, mouth bleeds, blood in the stool, heavy periods. any place there's a wet mucous membrane. So if you think about the lining of your nose, the lining of your mouth, your GI tract, it has mucus in it, and that mucus is produced by a single level of cells that maintain that mucus out on the surface. The challenging thing about mucous membranes is just immediately below that single level of cells, there's a very rich network of blood that has to help maintain those cells. And so the blood vessels are right up against the surface. And if you don't have good coagulation, especially if your platelets don't work well, you're going to bleed right away from that surface. And to make it a little bit more real, this is that single level of cells that are producing mucus on the outside. And look how close the blood vessels are. So you can see we're brushing your teeth vigorously, or if you have a cold and that mucous membrane breaks down, right away you're going to have bleeding if you don't have good coagulation, either clotting proteins, but especially platelet function. So here we come back. So now you're feeling more familiar with this slide, I know. Here's the tissue breakdown area. Here are your platelets. And so this takes us to all the relative frequency of other factor deficiencies. I know the majority of folks here have factor 8 or factor 9 deficiency or platelet dysfunction, but there are other rare clotting deficiencies. Here's factor 7, as I mentioned, that's a really big group. Factor 11 is also another major area of deficiency, but usually results in mild to moderate bleeding. Here's fibrinogen, another critically important protein. And so we want to understand much more about that. So how do we get from the gene to the protein? This is, I'll do this very quickly. Here's the chromosomes that carry all of our DNA information. And when we need to make a clotting protein, it begins to unravel. And so we use that as a template, a blueprint for protein. Your body says, hey, I need more factor 7 to be made. It opens up. The message for factor 7 comes out. It attaches to the ribosome. Transfer RNA that carries the amino acids for the production line come in and bind for each amino acid and follows the message exactly so that each of these amino acids in the protein are exactly the same every single time. Now, we do get one gene from each parent, so half the time the coding material will be coming from one parent and half the time it'll be coming from another parent, so dad's genome or mom's genome. So we can have a little bit of a mix, right? So someone that has factor 7 deficiency may get a normal gene from one parent and another gene for factor 7 that has a mutation. That's what we call a carrier state. And sometimes being a carrier, as we know in factor 8 and factor 9, you may actually have a dominance of that one gene and you actually get low enough to have some bleeding. That's true for all of the proteins we're learning now. We used to think that was just kind of true with the X-linked genes, but now we're learning, as we learn more about genomes, that there can be a dominance of one of the parents' gene over another. And so we're beginning to learn more about imprinting and about what controls gene expression. And we'll have more on that at some future lecture. So as that protein is made, each one of these amino acids has been programmed from your DNA, tissue factor protein, as well as factor 7 or factor 10. Here's the gene as it's read from the DNA. Pretty soon, though, a lot of the DNA, you realize that's read is not used, so it has to be clipped out. We call that spliced out. So eventually, the protein, as it's read and produced, has each of these domains. Here's that vitamin K domain for factor 7. Here's the enzyme portion. And when we look for variants, we look for mutations in these different portions. And sometimes knowing where the gene variant or mutation is can help predict whether someone is going to have severe disease or not. Sometimes we find genetic abnormalities also just in the cutting or splicing of the gene. All of these are very important. If you look at the protein in a cartoon fashion, then here it starts, the protein starts and the amino acids go along here and they curl up, and the protein curls up in some areas and it gets in different configurations. We can begin to look at those different domains of the protein and how they work. And the important thing I want you to know is that even for factor 7, there are different sites that do different jobs. And so knowing, here's that, again, vitamin K region, this is where it binds to the factor, the tissue factor. So we can begin to map mutations, variants to these different sites. And why is that important? If we look at families and we look at patients and we begin over time to see the same variant in the same region, and it's linked with a particular kind of bleeding pattern, that helps us to predict what the bleeding is going to be like for those patients or within a family. Now, why are genomics important? Well, for the patient, we hear over and over again, it helps them to know why they're bleeding and to identify what the problem is. For the hematologist, it helps us to link that phenotype and genotype. So you have this gene, what is your bleeding phenotype like? And can we begin to predict whether someone's going to be severe or not? Patients also need to know if they want to do prenatal or fetal screening so that they'll be prepared to whether they're going to have a child with a bleeding disorder or not. And these things are really important to the patients. For the hematologist, it also helps us know and develop new therapies specifically to treat that variant or mutation, because as I said before, it's not just replacement of the factors. Sometimes it's working with the braking mechanism, but now more importantly, it has to do with gene therapy. We're learning how to edit genes and correct the genes so that people actually experience at least a phenotypic cure. In other words, that their bleeding becomes more under control. And as some of my patients or the folks in our board say, you know, I just want to get up in the morning and not think about whether I have to infuse myself today or not. What a wonderful thing that would be. And to go out and do activities and know that you're not going to bleed. So that's really important. And it becomes important to society and healthcare so that we can document how we improve outcomes, lessen the burden of disease, and improve the quality of life for all patients. So the phenotypic characteristics, you know, we ask you about all these different bleeding symptoms. This happens to be for factor 13 deficiency, where there's a very high rate of intracranial or brain bleeds. They have bleeding at the umbilicus almost universally at birth. That we can make that diagnosis at birth when we have good pediatricians who recognize that that's an early sign of factor 13. So that's taught across the board to pediatricians and hematologists in the hopes that we can make an early diagnosis and prevent the intracranial hemorrhage. So how do we use a bleeding score to help us know about patients? Well, let's just take von Willebrand's. If you have a low von Willebrand's factor, and we take a history going back and we ask all of these questions and we assign a number to each of those bleeding tendencies, we can generate a score. The higher the score, the more bleeding there is. And what people first identified in von Willebrand's is that if you do a bleeding score, people with low levels of von Willebrand's, but falling within the normal range, their bleeding is really low. There's a few outliers up here that bleed, but the majority of people don't. Type 1 von Willebrand's, where the levels are much lower, they tend to bleed more. They fall into the low von Willebrand's category. Type 2, where the von Willebrand's protein doesn't always work, even though there's a circulating protein, their tendency is to have a much higher bleeding score. And here for type 3, that's where you have no von Willebrand's at all. And you know now how important that is for the blood vessel, for the platelet, and for the clotting protein. Look at the bleeding score. It's really, really significant. So these things help us predict for families a bleeding score, whether they're going to have a more severe course or a mild course, how to prepare for surgery, and who should be available for gene therapy. So let's use factor 7 as an example. we know that if there is a variant in the signal peptide that influences the circulating level, these patients have the lowest level both in the tissue and in the plasma, and look at their bleeding score. It's very, very high. The same is true for any mutations down here in the vitamin K region. Lots of bleeding, very high score. What if you have a variant in the region that actually binds to tissue factor up here in EGF2? That's a very important binding site. Wow, there's a lot of dysfunction in that protein and a lot of bleeding. Same with activation if you can't activate that protein. But look at here, this is lower than we thought. And this is the majority of factor 7 patients actually have a mild to moderate score. And that's in this enzymatic domain. So what we found was that there are a lot of variants that are out in this region, but only a few of them, really few patients, does it make a significance on their bleeding score. And if we begin to look at many, many, many patients, it helps us make that prediction better. So this is where understanding the very specific mutation, how it influences the protein and how that protein functions is key. I want to just at this point, and so this is we're getting toward the end, I just want to remind everybody that this work, the bulk of the work that we have done on sequencing many, many patients has been derived and led by patients who are out here having just a hell of a good time. More data is fun for them. And this data and research that I'm going to present to you was led, organized, and promoted by patients themselves. And it's given us, those of us doing research, a lot of data to look at and a lot of work, but it is making a huge difference in our understanding of how the protein works, which mutations are associated with bleeding, who's going to be at highest need for gene therapy and new therapies. So this was first initiated by something called My Life, Our Future, where patients came together through the NHF and through councils like yourselves to bring patients to participate through their HTCs to understand more about their factor mutations. And My Life, Our Future addressed the major group of patients, factor 8 deficiency, factor 9 deficiency. Von Willebrand's was being run out of Milwaukee, and over 900 new variants were identified through this process. My Life, Our Future ended about a year and a half ago. It's going to start again through Athens. And I think that it has a slightly different name, but again, we're going to pick up and continue to do sequencing, not just for patients, but for family members as well. It's very important, but kudos to families and patients. We started getting involved with CHEST. This is an organization that was formed by and for patients in order for them to hold educational sessions, much the way the council does, but it has the additional piece of trying to get some research done as part of their family meetings. And just like the council, I find that partnering with CHEST or councils that have partnered with CHEST to get some data together allows patients to lead the agenda. And this group met with different patient deficiency groups. It included factor 8 and factor 9 inhibitor deficiency, rare bleeding disorders, and women's health. They pulled me in under rare bleeding disorders, and they asked that we come and do gene sequencing for factor 7 and for Glanzmann's. And altogether, I think we've had a total of 4 episodes where CHEST and either a local council or NHF or one of the other organizations brought together families who were interested in having sequencing. So we not only sequenced the patient themselves, but also other family members, sometimes multiple generations, so that we could look at the gene and it would help us understand whether the variant was significant to bleeding, if it tracked with the bleeding, or whether it was an unknown variant that wasn't linked. Having family studies is key for us to understand new genes that haven't been described before. So throughout this, we've sequenced close to 425 individuals with either Glanzmann's or factor VII deficiency. The very first 2-day retreat, we had a total of 223 patients or individuals that we drew blood on. And I got to tell you, drawing blood over a period of 2 days from 223 people could only be accomplished by bringing our own terrific phlebotomist, a guy named Jaime Serna. Some of you from Orange County know Jaime. He's just a miracle worker when it comes to drawing blood. And we were able to draw over 200 patients in 48 hours. It was amazing. That was 105 patients, 88 families, and factor levels were obtained from the primary cares. And we did next-gen sequencing just on the gene itself, exons, introns, and 1,500 nucleotides up and downstream. That allowed us to look at whether a gene was dysfunctional or it was just not being produced. Long story short, out of that, we only had 3 patients where we couldn't find a variant. And that was pretty amazing, but is right around 2%. And that fits with other details. So probably we just didn't know the right place to look, or maybe we found a variant and we didn't think it was significant. So we continue to look at those 3 and see if we can find what the etiology is. But otherwise, everybody had their genetic change documented, and we found out of that first run 13 new patients. As I said, we've done this now 3 more times, and so we're up to over 400 patients with either factor VII. We also have done factor 13, which is an additional 150. So as part of this pilot work, Athens decided that they would like to do a My Life, Our Future, but for the rare coagulation disorders and for platelet dysfunction. And that has just now started. So if there's anyone in the audience or listening today that wants to have their gene sequenced and wants to have other family members sequenced for free, they can go to their HTC and say, I want to join Athens 10. Since we started, now we have over 15 sites initiated. We've gotten close to, just within weeks, we already have over 20 samples to sequence. And the goals are really to do the same thing as My Life, Our Future, to get the phenotype, the genotype, and help families understand what their variant is. We don't do this on people where there isn't a diagnosis. So in other words, you need to know that you have factor VII, Glanzmann's, or one of the other disorders. And also your HTC then will collect the bleeding information. They'll do the study with the factor levels. Paying attention to the time. So I'll get to the meat of this. There are 5 or 6 diagnoses that Athens has asked us to really focus on, although we will, although it says we're not, the proper thing would be to say we'll accept the sample, but we may not run it immediately. So if you have a patient, or if you only go to your HTC once a year, it's okay for them to draw and send us a blood sample. It's just that the turnaround time may be a little slower, and we'll just add you on to runs as we do them on the other specialties. So they've asked us to focus on fibrinogen deficiencies, factor VII, factor 13, Bernard-Soulier, and Glanzmann. And so if you have any of these, for sure get to your HTC, let them know that you want to get sequenced, and they will be done. If you have one of the other more rare disorders, it's okay to be drawn and have that sent to us. It's just that, as I said, there'll be a little bit more delay in getting the result back. The HTCs will ask you about your demographics, which means ethnicity, race, your medical history, which is really important, whether you've had bleeding with surgeries or not. Especially for rare disorders, they'll ask when you were diagnosed, but especially what's your bleeding history? Where do you bleed and how frequently, so they can generate that bleeding score. Very important. We just need one little blue, purple top tube, an EDTA tube. It's the kind of tube that you have a CBC done, and we don't need much. DNA is very stable. It lasts a long time. So even if we hold it for a few months before we run it, it'll be fine. And it's run in our lab, and the data will be incorporated into Clinical Manager. We're a CAP-CLIA lab, which means we'll also give an official report to your doctors. And it's important when that result comes through that you go over the results with your physician, and if you have one, a genetic counselor. And that'll help you understand the family distribution of that gene and its impact. Always very important. We're also doing some three-way calls with patients and their doctors in order to help interpret with some of the genetic findings as well. This is what's on our panel. So if there's anyone that has any of these deficiencies, or you know that you have, for example, factor 11 deficiency, factor 10 or 5, these are the Glanzmann's proteins. We also have some collagen receptor proteins on there. That's, as you can tell, something we're really interested in. But and we'll know for anybody that comes through with factor 7 deficiency, for example, we run all of these genes on each patient. So we will know for that factor 7 deficiency patient whether their collagen receptor has that mutation that is either high or low. So I think the important thing for you to know is that we're not just running your single gene, we're running your gene plus all of these other genes simultaneously. And it may help us to know if you have a minor gene modifying variant in any of these other proteins. And that's the strength of using a panel rather than just running one gene at a time. There are other ways that you can be involved in research. It's very, very important. AFN, which helps with research at all of our HTCs, they have many trials that you can participate in. The newest trial is AFN 16. Again, it's patient-based research. It is looking at a new product called 7-FACT, and which is a new kind of recombinant factor 7A for patients, factor 8 or 9 deficient patients that have an inhibitor. So Michelle, I just want to point out we're getting to the factor 8 and 9 patients. But this is a new product. People who have used Novo 7 in the past, this is very comparable to that. But the FDA and so on, they need to have more information, patient-based, real-time information about whether this product is working for you. So even though it's approved, we know it works, the emphasis is on the patient. They want to know, is it easy to use? Is it effective? Will it treat an acute bleed if you're a factor 8 or 9 patient with an inhibitor? If you want to have involvement in that research, again, just ask your HTC, say, I want to be part of AFN 13. I want to help answer that question. So you as a patient can help gather data on a new product. It's a short trial. They'll give you, I think it's 9 or 10 doses. It's free. They'll give you a smartphone application. You don't have to make on paper any kind of bleeding score. You can it's just immediately can be entered on your phone. And it's available for inhibitor patients, whether you have factor 8 or factor 9 deficiency. So just contract HTC. As I said, you become the citizen scientist and the patient researcher. This is a national study. And if on your bucket list is to be part of research or to lead it, this is your opportunity. Novo 7 is one of the traditional recombinant 7 that we've used. And it's also used for Glanzmann's and other bleeding disorders. 7-FACT, which is an activated process, factor 7 as well. The clinical trials were not done in platelet disorders, nor was it done for surgery. So current indication for 7-FACT is only for patients with inhibitors, with an acute bleed, and they can use that to stop the bleeding. This study that is being run by AFN starts at age 12. So if you have a child less than age 12, they do not qualify. But if you're 12 or above or an adult with an inhibitor, you would be welcome into this study. This is actually taken from the authorization pages for 7-Fact, because as I said, it is available, it's FDA approved, but I'm going to point out that we have a new way of getting our product authorized here in California. It's by a company called Magellan. So even if you are a state patient, if you would like to use this, we will need to get approval from Magellan, as we will need to get approval from Magellan for all of your prescriptions. This is a change in the California programs, and so I apologize if anyone's on the phone from outside of California. Getting access to these new medications, this is sort of an update that is important for all Californians to know. We're looking to see if this is going to slow us down at all. I know that the council has been very involved in tracking this and will continue to be involved, because if it's a step that slows down access to product, that's an important thing to know. But the Athens study, Athens 16, the product comes from them, and the trial is not dependent on Magellan. But if it is found to be useful, or if you're using it, this and any other product that we prescribe in the next, from here on in, will be approved by Magellan. So I'll just close on this and say thank you so much for putting up with what's sometimes what they call the just a war of arrows, right? The arrows and the red lines are really less important than understanding how the tissue factor works, how it stimulates the clotting process, how thrombin helps to activate the platelets, just as adhesion helps to activate the clotting system, and the importance of that clot retraction and stabilization with factor 13. So I hope I hit on all of the topics, Michelle, and I thank you all for your patience and attention, and also for that wonderful award. I really cherish it. Thank you very much.
Well, thank you.
Hi, Dr. Nugent.
Oh, good.
This is Dr. Sanchez. That was amazing. I love the discussion about the modifiers, about the sequencing. There's some excellent questions in the chat box. I hope we could sort of send them to you, and we could send it back to families, because they were just the whole spectrum. A lot of the studies that you mentioned were run through the HTCs. Some of our families don't go to HTCs, so will they qualify?
If they would like to have their gene sequenced, they can contact us at CIBD. We've been doing this gene sequencing, of course. The Athens project has just started a month ago, but we've been doing gene sequencing for patients now for over 3 or 4 years using the panel. What's great about moving to Athens is it really allowed us to improve how we look at the genes. You know, you're probably familiar with the Nugent clinical analyzing system. So that added some cost per run. It costs us about $50 more per patient to put the analysis through that, but it's been incredibly powerful. And so our reporting has gotten much faster. I'll just leave it at that. So if people want to reach out to me through the CIBD, we're happy to sequence them. They don't have to go through Athens 10 to get their sequencing done.
Thank you for that, because we did have a link on our website about clinical trials in Southern California. We desperately need to update that, and I really want to encourage everybody to sign up for as many clinical trials as you deem necessary, asking, of course, all the appropriate questions. But this is how we further research, how we further treatment for ourselves. My son was on the Profi study with Marilyn Manco Johnson many years ago. That insurance was able to then cover Profi treatment for people with severe hemo A and hemo B. So important. And I wish, Dr. Nugent, you could see the chat blowing up like crazy. First of all, everybody now wants to go and see you. Everybody wants to do all these tests. There are so many questions, but because we are running a little bit behind, what I'm going to do is forward those questions to you, Dr. Nugent, and copy Dr.
Excellent.
Sanchez, and then I will email everyone the answer to your questions. And, you know, I did want to say that I did give you a huge project and I would not have asked that to just anybody. And I knew that you would be able to handle it. I'm sorry that I did that, but this was absolutely phenomenal. I don't think we've ever, at least in our community, heard a presentation like this. People are so excited. We learned so much. I wish we could have you every time, but I know, listen, folks, it's been like 5 years and I got Dr. Nugent. So she is so busy. You have to understand, she is globally renowned. Everybody wants her as a speaker and you can see why, but we are so thankful to have you today. And you're just in our
you're very kind. And let me just say, and Pedro knows this because he works at a great center too, is that we are a community of treaters. We have such wonderful hematology specialists throughout Southern California, actually throughout the state. But it's coming together as a group, your treaters, the patients, all the providers, and sharing information and sharing best practice like we do. I enjoy hearing the other doctors speak because I learned so much too. And throughout our community, we have great treaters and people who really are compassionate and care a lot about the bleeding disorder community. We're so lucky in this region. And you're doing a great job with leadership. And you and your board have been incredibly strong. And I know a lot of my patients are part of your organization, and we just really appreciate it. Thank you so much.
Thank you. Thank you, everybody. So